Hello there and welcome to a new video tutorial on tests used in rheumatology. I'm Dr. Ishfaq and I'm a resident medical officer of internal medicine at a COVID-19 specialized treatment center in Sri Lanka. So, uh, talking about rheumatology, rheumatology is one of the fields which has most of the overlap syndromes. So, correctly diagnosing it's a really big task. So, like I say, investigations are always not the first step. You need to get a thorough clinical history and you need to do a relevant clinical examination, and then you decide what's the relevant investigations you need in order to exclude certain things. So what have we got? We got some blood screening tests, we got serum autoantibody tests, we got joint aspirations, diagnostic imaging and visualizations. So it's a mouthful. Let's talk about some blood screening tests. Now, these are basically a basic panel which might show you certain abnormalities in certain systems. When you take a full blood count, you first of all, you look at hemoglobin levels, right? So, in patients with chronic inflammatory disease, you tend to see a normocytic chromic anemia. And also in patients with rheumatoid arthritis, osteoarthritis, articular diseases, they take a lot of NSAIDs. So NSAID gastropathy, it can lead to GI bleeding and cause a hypochromic microcytic anemia. What about WBCs? You can see a neutrophilia in septic arthritis and even patients on steroid therapy. And also you can see lymphopenia in certain viral arthritis and viral conditions, and even active SLE can cause a lymphopenia. When you see a neutropenia on your blood work, you should always see, are there any drugs which is inducing a bone marrow suppression? So some conditions can produce eosinophilia as well, like Jhogran, etc. What about ESR and CRP? Both of them are pro-inflammatory markers. So whenever there is an inflammation, whether it's due to an infection, whether it's due to some autoimmune process, the inflammatory markers will rise. In chronic inflammatory disease, the viscosity of the plasma rises, so the ESR will rise. What about the liver profile? Patients on long-term chemotherapy, they can have drug-induced liver injury. To exclude them and check your liver function, liver profile is very important, especially getting enzyme levels like ASTs and ALTs. A single rise in alkaline phosphatase will, however, signify a bone disease, but altogether with AST and ALT and correlating clinical picture, you can come up to a conclusion of a liver injury. So always remember that investigations must be correlated with the clinical picture. There are some other blood and urine tests as well. Serum protein electrophoresis. This is used to exclude multiple myeloma in patients with high ESR, back pain. So, this here you see is a serum protein electrophoresis, and in patients with multiple myeloma, the amount of gamma globulin will rise, leading to a M spike, right? Normally you don't see the M spike, right? Serum uric acids used to evaluate for gout. ASOT, antistreptolysin O titer. It fulfills the diagnostic criteria for rheumatic fever, right? Serum autoantibody tests, man, that's a mouthful. Look at the list here, right? These are the autoantibodies, and let me correct myself, these are some of the autoantibodies, right? We are not going to talk everything in detail, but we are going to touch most of them which are clinically relevant. So autoantibodies are antibodies against ourselves, right? So first of all, let's talk about rheumatoid factor. What's a rheumatoid factor? It is an antibody. What sort of antibody? It's an IgM antibody. It's an IgM against the FC portion of the IgG. So it's an IgM against our IgG. Occasionally it can be IgA as well. It is detected by agglutination tests, which means you put the serum of the patient together with IgG coated latex particles, and if the antibodies binds to these latex particles, they cause an agglutination, and that's how we detect it. So it's detected in 70% patients with rheumatoid arthritis, but that's not diagnostic. But you got to remember that high titers in early rheumatoid arthritis will definitely show a poor prognosis. They are detected in many other autoimmune conditions as well. So look at the chart here. I've taken this from the Kumar and Clark 10th edition. Pretty interesting table where it shows the conditions where you can find rheumatoid factor being positive, right? There are autoimmune rheumatic diseases, there are viral infections, and there are chronic infections as well. Meanwhile, do check out Medicosis Perfectionalis YouTube's channel. You know, it's a really informative channel which talks about these investigations in rather amazing detail with really amazing annotations. Really good to follow for beginners. Citrulinated cyclic peptide antibodies, anti-CCP. Yeah. Now, what's this jargon? Yeah. Anticyclic citrulinated peptide antibody testing is particularly useful in the diagnosis of rheumatoid arthritis. So it is with high specificity, presents early in the disease process, and the ability to identify patients who are likely to have disease, to have severe disease and irreversible damage. So having anti-CCP in early disease definitely reflects on some irreversible changes happening. The generation of these antibodies is an early event in the disease course, and it's dependent on the presence of certain MHC class II alleles. So these antibodies in the inflamed synovium has been shown to associate with citrulinated antigens to form immune complexes. Now, what are these citrulinated antigens? I'll get back to you soon. So they result in a progression of the inflammatory process. So while I said Medicosis Perfectionalis, great videos and amazing content, just do check it out. So what's citrulination? It is actually a physiological process that occurs in many dying cells. Citrulline is a non-standard amino acid that is produced by diminution of arginine residue. Make note that it is not deamination, it is diminution, right? So this happens in the presence of an enzyme PAD. What's PAD? Peptidyl arginine deaminase. This peptidyl arginine deaminase enzyme has several isoforms, of which PAD2 and PAD4 are expressed in inflammatory leukocytes. Well, how interesting. So the release of PAD from dying cells technically citrulinates extracellular proteins that contain arginine. So the production of anti-citrulinated protein antibody depends on the genetic background of the patients, which means the MHC alleles. So you see here this amino acid residue having arginine in the presence of PAD becoming a peptidyl citrulline. So this citrulline usually takes a cyclic form, so hence it's called a cyclic citrulinated peptide. So here you see a joint surface and you see some glycoproteins on the joint surface which has a arginine residue. So now you see the GRAN team, the granulocyte team, which comes and pose the enzyme PAD. Now in the presence of PAD, the reaction happens and these peptides gets diminuted and gets citrulinated. So what happens is, against these citrulinated antigens, you form antibodies, and that's basically anticyclic citrulinated peptides. On a side note, it's very specific in rheumatoid arthritis but not sensitive as rheumatoid factor. Having high titers of anti-CCP and rheumatoid factor at diagnosis predicts an erosive arthritis and extra-articular manifestations as well. So treatment should be started promptly. So what about anti-nuclear antibodies? Anti-nuclear antibodies are basically antibodies acting against the nucleus and the nuclear components. It's one of the major autoantibodies which we check during rheumatological conditions. Now the anti-nuclear antibody is a defining feature of the connective tissue autoimmune disorders. So ANAs are a class of antibodies that bind to cellular components in the nucleus, not anywhere else. It's a nuclear antibody. So it can bind to DNA, RNA, nucleic acid protein complexes, and also proteins within the nucleus. Antinuclear antibodies refer to an autoantibody directed at material within the nucleus of the cell. So ANAs typically classify in two groups. So antibodies to nuclear material and antibodies to DNA and histones. So basically antibodies to nuclear material and antibodies to DNA and histones. Antibodies to DNA and histones include anti-double-stranded DNA antibodies and antihistone antibodies. The remaining category includes an additional targeted nuclear antigen. The first one of them was antismith antibody, which I'll be talking about, and others include the anti-Rho, anti-La, anti-ribonucleoproteins, anti-centromere antibodies, anti-Scleroderma 70s, and anti-Jo. Let's talk about anti-double-stranded DNA antibody. Yeah, they are DNAs where the antigen is your double-stranded DNA. Usually it's detected by ELISA or immunofluorescence. It's a diagnostic of active SLE. So basically anti-dsDNA shows the disease severity. Will ANA show the disease severity? No. You should not repeat ANA. Once the patient has positive ANA, even if he has an active disease or not, no point in repeating ANA because it does not correlate with disease severity. In SLE flare, the titers will rise, and on treatment it may come down. So dsDNA definitely correlates with the disease severity. Some SLE patients can have a higher disease activity but yet normal double-stranded DNA antibodies. So in that case, what we can do is to monitor the antibody titers and correlate with the disease severity in order to see if at all the dsDNA is correlating. On a side note, patients who are on long-term TNF-alpha inhibitors like infliximab have a positive titer of anti-dsDNA. How do they even form? So well, you have a cell which has got a defective apoptosis, and what happens is due to that there will be double-stranded DNA extracellularly. So what happens? There won't be anyone to come and clean up the mess. So what happens? The antigen presenting cells presents the dsDNA to a helper T cell. That helper T cells presents it to a B cell, a plasma cell, and plasma cells ends up producing many antibodies which ultimately attack your double-stranded DNA. Yep, antismith antibody, fancy name, huh? Antismith antibody was actually detected quite long ago in a patient called Stephen Smith. He apparently had systemic lupus erythematosus, and they've coincidentally found antismith antibodies, some antibodies, and eventually they named it as antismith in order to honor his name. So it's antibodies against a nuclear protein. What's the protein? What's the antigen? It's the Smith antigen. They are protein complexes to a nuclear ribonucleoprotein. They are protein complexes to a nuclear ribonucleoprotein. So 25% of SLE patients got anti-Smith. However, they are not sensitive. They are seen mainly in SLE, so they are very specific. However, they don't correlate with disease activity. Just remember that anti-Smith is a very specific thing for SLE. Anti-U1RNP antibody. What's a U1RNP? It's a ribonucleoprotein. What's a ribonucleoprotein? It's a protein in the nucleus which contains some RNA within it. So they are antibodies against this particular RNP, a ribonucleoprotein, snRNP70. So this antibody can be found in overlap conditions like mixed connective tissue diseases. So it is very sensitive but not specific. It means the absence of RNP almost excludes the condition of having the diagnosis of mixed connective tissue disease. Hence, it's very sensitive. Usually, double-stranded DNA antibodies occur together with anti-RNP antibodies. So it's just a side note to remember. Anti-Rho and anti-La, anti-SSA, anti-SSB, the jargon tells the same thing. What's that? They are detected in Jhogran Syndrome. See, SS, Jhogran Syndrome, SS, Jhogran Syndrome. They are detected in Jhogran Syndrome and SLE2. So this ain't specific. This is associated with lupus nephritis as well. So in lupus nephritis, what are the things you'll be finding? You'll be finding double-stranded DNA as well. So double-stranded DNA together with SSA indicates that in SLE, there's an involvement of the kidney, lupus nephritis. People with anti-SSA antibodies can have a positive HLA-DR3 too. We'll talk about HLA-DR3 in a completely different video tutorial. You see, Jhogran syndrome, mainly dry eyes, dry mouth, dry tongue. Yeah, gritty sensations in the eye are the common complaints of Jhogran syndrome. You see, lupus nephritis is associated with double-stranded DNA and anti-Rho. What about anti-La, SSB? This is also associated with Jhogran syndrome, as you have the SS here. Also, it's seen in SLE as well. It's not specific, nor sensitive either. Having anti-SSB with Jhogran syndrome will bring a risk of developing non-Hodgkin's lymphoma, and to note that anti-La antibodies have no relation with lupus nephritis. So what I want to mention is having Jhogran syndrome and having anti-SSA and anti-SSB, or having only anti-SSB, however, increases the risk of having non-Hodgkin's lymphomas. Now let's talk about antihistone antibodies. What's antihistone antibodies? Now, what's a histone first of all? You see here, this is your double-stranded DNA which eventually binds together and cuddles around a histone protein. These histone proteins all clump together to form the classical structure of a heterochromatin. So you need histones to keep your chromosomes intact. So there's a condition where drugs causes a drugs-induced lupus. It's not in systemic lupus erythematosus, it's basically a drug-induced lupus. What are the drugs which causes lupus? It's time for a mnemonic. I hate multiple meds causing queer problems, right? INH, isoniazid, hydralazine, minocycline, methyl-dopa, chlorpromazine, quinidine, procainamide. So just use this mnemonic and make sure you remember it for your boards. Drug-induced lupus. They are antibodies against histones. Drug-induced lupus has more than 95% sensitivity. So more than 95% of people having drug-induced lupus has positive antihistone bodies. So it definitely is damn sensitive. So a negative antihistone antibody can definitely rule out drug-induced lupus. In rare occasions, drug-induced lupus can have a positive P-ANCA values. What's a P-ANCA? It's a perinuclear antinuclear cytoplasmic antibody. So, my God, what's that jargon? Let me talk to you about it a bit later. Just hang on, keep it on a side note that drug-induced lupus can have P-ANCA levels on rare occasions. Now, let's just quickly, talk about scleroderma. What's a scleroderma? Scleroderma, there's a diffuse type of scleroderma, which is systemic sclerosis. You find two antibodies. You find anti-RNA polymerase and Antiscleroderma 70. Both of them are very suggestive of diffuse disease. In a limited disease or crust syndrome, you only find anticentromere antibodies. So just remember this. What's an anticentromere antibody? It's the antibody against a centromere. What's a centromere? Centromere is a protein structure which is mainly used to divide the chromosomes into two during mitosis, right? Mitosis, meiosis. So this shows a risk of isolated pulmonary arterial hypertension. Do remember that anticentromere antibody indicates a limited disease of scleroderma. So having a limited disease of scleroderma with anticentromere antibody, however, shows a risk of developing an isolated pulmonary arterial hypertension. They are antibodies against centromeres, extremely specific. Well, 30% of patients with systemic sclerosis may have this antibody. Patients with primary biliary cirrhosis will have this antibody, and it definitely shows the presence of portal hypertension. This is just an additional thing which you can remember. Anti-RNA polymerase 3, it's an antibody like Antiscleroderma 70, which is very specific with systemic sclerosis. Now, what do they indicate? What do they correlate with? They correlate with a systemic sclerosis renal crisis. They correlate with increased risk of carcinomas. They correlate with increased risk of pulmonary arterial hypertension. And they also correlate with increased risk of skin disease. Now, what are the carcinomas we're talking about? We're talking about lung cancer and esophageal cancer. Why do we have esophageal cancer? Due to the sclerotic type of involvement of the GIT, you have a consistent reflux. That reflux causes esophageal carcinomas. What about lung cancer? You develop interstitial lung disease. This interstitial lung disease will end up in repetitive injury and repair, which will eventually lead to metaplasia and neoplastic changes leading to lung cancer. Anti-Jo antibody. What's an anti-Jo antibody? It's an antibody against a synthetase. What's synthetase? Synthetase is an enzyme which has this structure. Man, it's complicated, is it? No, it's not. This is just an ATP synthetase enzyme which has a supercool structure here, which will bind the inorganic phosphate with ADP and release ATP. So basically, it's an antibody against a tRNA synthetase enzyme. They are associated with myositis. In patients with myositis, having this antibody will definitely have a risk of interstitial lung disease. So that's about anti-Jo antibody. Now let's look at other important antibodies. Now what are they? The all famous ANCA. What's an ANCA? Antineutrophilic cytoplasmic antibodies. Make sure you remember cytoplasmic. They are not antinuclear antibodies. They are antibodies against the cytoplasm of the neutrophil or a monocyte. It can be detected using ELISA or immune fluorescence. ELISA directly detects you the protein itself, and the immune fluorescence, basically there is an inter-rater dependence. So I would say that ELISA will be always having a better hand in detecting the ANCAs. They are usually associated with small vessel vasculitis. Vasculitis is a plural for vasculitis. So they are usually associated with small vessel vasculitis. It does not, however, tell the disease severity. Well, we have two ANCA antibodies which we have to mainly learn about, the C-ANCA and the P-ANCA. C-ANCA is the cytoplasmic ANCA, where you see the antibodies are usually in the cytoplasm. But P-ANCA, what's P? It's a perinuclear antibody. It binds to the cytoplasm or joining the nucleus, right? That's what you see here. The cytoplasm of neutrophil and monocyte has got the protein proteinase 3, PR3. It's not per rectum, it's PR. These antibodies are bound to PR3. So you see C is the third letter in the alphabet. So you see a uniform cytoplasmic staining. So that's C-ANCA. P-ANCA, in the other hand, it's a perinuclear antibody. It binds to myeloperoxidases in the cytoplasm of neutrophils and monocytes. These antibodies bind to myeloperoxidase because myeloperoxidase produces free radicals which are negatively charged, and P-ANCA is positively charged. Remember, P for positive, P-ANCA, perinuclear. So C-ANCA and P-ANCA is clear. Let's do some more on ANCAs. PR3 and myeloperoxidase are both found in azurophilic granules in neutrophilic cytoplasm. Basically, when TNF-alpha primes the PMNs, these granules come closer to the surface of the plasma membrane and interacts with these antibodies. Then what happens is that they trigger degranulation, causing inflammation. Please excuse my spelling. Then it triggers degranulation and causing inflammation. On a side note, remember that these antibodies are bound to vascular endothelium. That triggers the chemotaxis and PMNs to the vessel walls, involving in a systemic small vessel vasculitis. C-ANCA, P-ANCA. You see C-ANCA only in veganers, which is granulomatosis with polyangiitis. All the other conditions you see P-ANCA. Microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, which is Churg-Strauss, drug-induced ANCA, associated vasculitis. Listen to this. I've been telling you during drug-induced lupus that you can also find some P-ANCA positive in drug-induced lupus. Yes, this is what I'm talking about. Drug-induced ANCA associated vasculitis. POSI, immune necrotizing crescentic glomerulonephritis. It's also called as rapidly progressive glomerulonephritis. Goodpasture syndrome, autoimmune hepatitis, inflammatory bowel disease, primary sclerosing cholangitis. Man, it's a mouthful. So you know all of them are in P-ANCA, only one in C-ANCA. Antiphospholipid antibodies. What's antiphospholipid antibodies? The principal antigen is beta-2 glycoprotein 1. Especially this antigen binds to cardiolipin and other anionic phospholipids. So it's seen in antiphospholipid syndrome and also seen in SLE. It's detected by ELISA. What happens here? Antibodies against this is called lupus anticoagulant. Man, why do we call it anticoagulant? Because it prolongs the APTT in vitro. But however, this condition produces a hypercoagulable state. This antigen-antibody complex somehow activates the cells, leading into thrombus involving deep vein thrombosis, pulmonary embolisms, and coronary artery disease and strokes. Well, pathogenesis more deeply involved. These circulating antiphospholipid antibodies with an underlying endothelial dysfunction, however, causes all this mouthful eventually activating platelets, damaging the endothelial surface, somehow promoting thrombosis, and venous thromboembolisms, arterial thrombosis, adverse obstetric events, recurrent miscarriages, accelerated atherosclerosis, risk of myocardial infarctions and strokes, and valvular heart diseases. So antiphospholipid syndrome, definitely a clear-cut pathogenesis. Hypocomplementemia, that means a reduction in complement levels. Now, why is that happening? We got three pathways of complements. Why do we have three pathways of complements? Because each will have different ways where it is triggered. Classical pathway is triggered by antigen antibody complexes. Alternate pathways triggered by bacterial endotoxins. Lectins are triggered by lectin binding mannoses. So basically, in autoimmune conditions where we have autoantibodies, there is always a type 3 hypersensitivity reaction which always contains circulating antigen antibody complexes. These trigger the classical pathway of the complement cascade that causes an overuse of complements. This overuse of factors will ultimately lead to hypocomplementemia, and this also can be detected to somehow get an idea about the disease activity. How do you assess this? There's something called the Ch50 levels. It is actually used to assess the severity of the classical pathway. If we got a condition which has led to an overuse of the classical pathway, some complement components will be insufficient or absent. This will cause a low Ch50 value. Then according to the clinical presentation, we got to test the individual complements. Now how do we know that? Let's talk about the classical pathway. The antigen antibody complexes somehow activate C1QR. This activation of C1QR somehow cleaves C4 and C2. The collection of C4b together with C2a is called a C3 convertase, which cleaves C3. C3b together with C3 convertase is called a C5 convertase, which cleaves C5 into C5b and A. The C5b together with the C6, 7, 8, 9 causes the membrane attack complex, which goes and ultimately attacks the target and causes the injury. So in the alternate pathway, it starts in a different way and ultimately comes and ends up in this final last terminal complements. That is why in infections like Neisseria, you have to test the C5 to C9 in case you have a low C50 levels. But if there is no history of infections, it's a clinical picture suggestive of more of an autoimmune disease. Better start off with the early complements, because antigen antibody complexes do start the cascade. So a low C1, C2, C4 definitely shows the disease activity. Now I think it's enough with all those blood investigations. Let's move into some interesting stuff. Joint aspirations. What is he doing here? He's taking some fluid out of the knee joint. Joint aspirations are done in cases where there is a fluctuant collection felt in the joint. It's mainly to diagnose septic arthritis, reactive arthritis, or crystal arthropathies. The nature of the fluid is always an indicator of the level of inflammation. There's clear fluid to pus. Now basically the decision to perform a joint aspiration comes after looking at the clinical picture. If the patient is coming with fever, severe reduction of joint movement, hot and warm swollen joint, definitely you think about septic arthritis. You definitely have to aspirate the joint and see if there is pus. Definitely that joint has to be drained, washed, and treated with IV antibiotics. Whereas the other case where there is a reactive arthritis or crystal arthropathies, washout is not needed. So basically that's the main sense of having joint aspiration. Diagnostic imaging and visualization. Well, this is always not the first step, but definitely X-rays can be diagnostic in certain conditions like rheumatoid arthritis, osteoarthritis. Like, look at this. Isn't this so classical? You see the ulnar deviations in rheumatoid arthritis. Look at this. This is a normal knee joint, and in osteoarthritis you see the medial segment where there's a loss of joint space having bone spurs, whereas in rheumatoid arthritis you see the subchondral sclerosis, and this is osteoarthritis. So X-rays do give you a valuable information on the disease process. Ultrasound scans are now highly used to see the periarticular structures and soft tissues, swellings in soft tissues and tendons, etc. Now it's increasingly used to examine the shoulder joint during movement to exclude and visualize impingement syndromes. And also it's used to guide the needle during aspirations and injections. You see this here, supraspinatus tendon, infraspinatus tendon, and you see there is a tear in this region which is completely depicted in an ultrasound scan. Well, you've got to have the skill to operate and interpret, but somehow it's a valuable asset of diagnostic imaging. MRI scans, magnetic resonance imaging. It is more sensitive than X-rays in early stages of articular disease. It's the investigation of choice in some conditions, gives more clarity in soft tissue imaging. Contrast like gadolinium injections enhances inflamed tissues, so muscle pathologies like myositis can be evident. See this, a normal muscle should be weighted dark, but with gadolinium, when there is an edema and inflammation, it appears bright. So myositis can be detected in that way. Dexa scanning. What's Dexa? Dexa is actually dual energy X-ray absorptiometry. It's basically to test the bone density. You get a T-score after you've had your Dexa scan, and depending on your T-score, you'll be assessed and given an assessment on your bone density. So they usually take your images of your hip and spine, and that's sort of the instrument which you've got. Well, that's all for the investigations of rheumatology, and please do check out my YouTube channel. There are much more videos to see. Do take a look and leave your valuable comments, and that's how we improve the channel. And do follow us on Facebook, Instagram, and if this video helped you, just like and subscribe and hit the bell icon so that you'll get a notification when we post a new video. And please like, do share, and do subscribe. And thank you so much, and see you on our next video tutorial.